Hello and thank you so much for joining us today for the webinar Navigate More Fun in Implantology, Digital Diagnosis, Virtual Planning, Navigated Surgical Technique. It is a great pleasure to introduce to you Dr. Severin Holl. The lecture of Dr. Severin Holl contains numerous videos that impressively document patient cases and all steps from the implant planning to the final restoration. The main topics are the digital workflow, the basics of 3D X-ray devices, virtual planning and prosthetic implementation, indication spectrum of digital implantology. We would like to thank Dr. Holl for being with us today and KaVo for making this lecture possible. Please take note of any questions and comments you have during the lecture, as they will be addressed by Dr. Holl at the end of the presentation. Without any further delay, please help me welcome the expert himself, Dr. Severin Holl.
Yeah, hello, and thank you very much for the introduction. Okay, let's start my presentation by showing you how we integrated the new digital technologies in the field of implantology in our dental practice. You will see different implant systems which we have tested in combination with the navigated surgery. For us, the legacy and interactive system is best suited for the combination with the digital workflow of the navigated surgery. So we use only these systems in our practice since last year. When we look at our dental practice today, we realize that in the last 10 years, digitalization has made a massive entry. Let's take a look at the field of X-ray technology. Today, whether it's with sensor or foil technology, we achieve a result that, compared to analog film, is qualitatively better. Or consider the possibility of radiation-free caries diagnosis using the diagnocam from KaVo. With a wavelength close to the infrared spectrum, caries can be detected and documented. On the right side, you see a significant enamel caries in the distal region. For us is, of course, the field of implantology especially interesting. Since the development of CBCT, we are able to evaluate the bone situation in all 3 dimensions. Finally, we had the missing 3rd dimension, and it was only logical that with appropriate planning programs, the navigated surgery was established in our dental practice. That is what we like to show you today. But let us first take a look at the already today possible digital workflow in order to implement the principle of backward planning. This means the prosthetic tooth position determines the implant position. The video, please. Let's start this short video. These 10 steps initially starts with the X-ray of the patient. In the second step, we can digitally record the lower jaw movements with the help of the arcostigma and load these movements into our CAD/CAM software. In the third step, we digitalize our analog stone model with the help of an optical scanner. With these data, we can now start a prosthetic plan in our CAD/CAM software Multicad. With the virtual articulator, we achieve the correct occlusal surface. In our 5th step, we move on to the surgical planning by superimposing our CBCT and the optical scan of the stone model. Then we import the prosthetic planning in our software, and thus we have the basis for a correct implant planning. In the next step, we are planning the implant position with regard to a correct implant axis, This file of our planning, which we call project, is the basis for the manufacturing of the surgical template. The templates are made with a 3D printer at the company KaVo. With the help of this surgery template, we carry out the navigated surgery. More on that later. If desired, you can produce either an immediate restoration or a definitive bridge with the CAD/CAM method. In summary, we can say that if you use the digital workflow of the prosthetic treatment of our patients, we can reach a predictable and safe result. And today, it's basically possible. To prevent you from thinking that we are only showing simulated cases, here are the clinical pictures of the patient. The patient came from Italy only for a short stay to have the implant surgery done at our practice. That is why we performed this surgery flapless. On the left side you can see the surgical template in place, and on the right side the surgery result. A frequent criticism in Germany of flapless surgery is the limited possibility of control due to the closed procedure. A certain curve of learning is of course necessary when we use the flapless method. To check the osseous cavity through the surgical template and to guarantee a correct positioning of the implants. 2 years later you can recognize a perfect situation without any loss of bone. The prosthetic restoration was carried out with Emax ceramic crowns from Vivadent. What safety do we have today when we use these technologies? We can conclude that the CBCT has become an established examination method in dentistry. We have now been using it in our practices for 15 years, and we can detect a significant increase in the quality of our work. But especially in the field of implantology, with the help of CBCT, new methods of treatment came up. But no innovation without pros and cons. The main criticism of the cone beam is the increased radiation exposure compared to our dental X-ray technology. In general, you can say that a CBCT produces a 10 times higher dose of radiation than a panoramic image. In order to meet the ALARA principle, we have the following options. On one hand, we can reduce the volume of the CBCT to the smallest size necessary for the indication. And on the other hand, we can use the new low-dose technique equipment from KaVo. If we take a look at the radiation exposure of our dental radiography, we have for intraoral and bite-wing about 2 to 5 microsievert. A panoramic picture needs about 14 to 24 microsievert. Now consider the values of the new OP 300 Maxio from KaVo. For implant planning, a volume of 8 to 6 centimeters is definitely sufficient. And if you now look at the radiation dose of about 14 microsievert, you can see that we are absolutely in the range of a panoramic image. Thus, we have no higher radiation exposure compared to a two-dimensional planning. Of course, we have a loss of accuracy with the low-dose technology and consequently a resolution in the range of 200 microns. In the high definition for endodontics, the OP300 reaches an accuracy of 85 microns. But for a surgical situation in the bone, the low resolution is quite sufficient. But why should we use a three-dimensional planning? Consider the failure in the aesthetic zone, which we can see in this slide. The CBCT on the right side shows that this bone isn't sufficient for an implant or for an aesthetic implant position. In the CBCT cross-section, you can recognize there isn't any bone buckle of the implant. You will hardly believe it was already the second attempt of implantation. This is only the picture which does not come from our practice. The patient came to my friend Professor Axel Spar in Sydney for surgery. A prior CBCT and a backward planning could have prevented this failure. Another reason for a three-dimensional design you can see here. The green line shows the gingiva. This mandible in the posterior region shows in the panoramic image a height of 16 millimeters. What would be perfectly adequate for an implant. But if we consider this cross-section, we can see a balcony which does not allow a simple implantation. Or take this parallelism of these implants. I claim, three-handed, I cannot guarantee this result. A predictable accuracy as shown here, for me is only possible with a navigated surgical technique. In this case, on the left side you can see additionally a very small width of the jawbone. Recognizable are the gingiva, it's the green line, and the entrance of the foramen mentale. On the right side, you see the surgery result with legacy 3. Meanwhile, the premolar was extracted. A few more pictures to the prosthetic. The impression is taken with the legacy abutments in which we fixed the longer screws so they can be removed more easily. On the right side you see the impression with polyether. And here is the final restoration with the ceramic finished bridge, the X-ray and the cemented bridge on the abutments. Let us sum up the advantages of 3D planning. With the help of the cone beam, we get a detailed reproduction of the bone situation without distortion as in a panoramic image. We can implement the backward planning principle with the virtual implant plan on the computer. We get predictability with regard to material and costs, as well as a perfect basis for patient education on the computer screen. For ourselves, we get a better estimation for the operating time, and it also gives us the opportunity to operate flapless, which is especially interesting for our elderly patients. Ultimately, we obtain treatments with predictable and reproducible results. Let's start with the planning. Of course, we need to download the software. We use the software IntoGuide from the company Cybermed, a module of the software package On Demand 3D, which comes with all KaVo 3D X-ray devices. If you go to the link intoguide.eu, you will find a trial version for downloading. Let's talk about the different planning concepts. The easiest planning is the partially edentulous jaw. What do we need? We need the CBCT of the patient and a digital plaster model of the jaw. Both images we can produce in our practice with the cone beam. The results can be seen here. On the left side, you see the X-ray of the patient. Only the hard tissues are illustrated by the CBCT, the jawbone and the teeth. On the right side, you see the scan of the plaster model. This shows us the situation of the oral cavity with teeth and gums. We superimpose these two scans. For this purpose, we mark identical tooth areas in both images. You can see the green marking, the yellow marking, and the red marking. With these points, the program superimposes both images. Here is the result. Top left, we see the white X-ray. This CBCT is overlaid by our blue blaster model. The indicated cross-section is shown on the top right. The green line is again our plaster model and represents the gingival situation of the patient. Below you can see the panoramic image with the nervus alveolaris inferior. With this basis, we can perform an accurate implant planning in all levels, taking the bone into account and the security area around the implant. This planning data are uploaded to KaVo. There, the manufacturing of the surgical templates is carried out. The manufacturing of the surgical template and the operation technique we want to consider in detail. After the dental technician has checked the data, she designs and produces the surgical template with the help of a 3D printer. In the picture, you see this printer. If questions arise, they will call you. Then the colored metallic sleeves are glued into the acrylic base. The template is subjected to a strict quality control. Each sleeve must hold a weight of 5 kg. However, it is important to know how precisely the template fits in the mouth. That you can see in this picture. You recognize the white cusp tip in the surgical template without any gap. We come to the principle of surgery. Each sleeve is color-coded and available in different diameters, depending on the wishes of the dentist. This universal kit from IntoGuide offers corresponding color-coded drills to avoid failures. On the right side, you see the spoon-like instruments to reduce the diameter of the sleeves for a gradual preparation of the osseous cavity. Here are some pictures for a better understanding. You can see an open flap surgery. On the left side, you see the spoon-like instrument with the corresponding yellow drill for the yellow sleeve. On the right side, you can see a bone condensing, which you can also perform with the template. How exactly the planned implant position is realized, you can see in this photo. A perfectly centric implant position. Here are some pictures of this patient's case. After the loss of the incisor, we decided to restore the previously existing diastema with an implant. Now you may be wondering, where is the diastema? During the period of the temporary bridge, the patient felt the situation more aesthetic as the diastema before, and so we had to make a gap closure with the definitive restoration. Anyway, that is the result. Let's watch a short video over a tooth-borne surgical template. First, you see the surgical unit master search from KaVo. The surgical kit from IntoGuide, Implant Direct, and the universal kit from IntoGuide. We show a flapless surgery. First, we insert the surgical template. After that, we start with the gingiva punch. To detach the gingiva from the bone, we take the template off again, reworking the punch and remove the gingiva with a sharp spoon. We put the template back and pierce the cortical bone with the initial drill. Thereafter, the preparation of the implant cavity is carried out. Therefore, we reduce the diameter of the sleeves with the instruments. By increasing the drill diameter, we achieve a gradual preparation of the osseous cavity. The bone chips are collected for a later sinus elevation. For the last drill, we use the original surgery kit. Now, we break the sinus floor with the osteotome and insert the bone chips. The last step, screwing the interactive implant, initially using the handpiece, and the last turns by hand. As you can see, we have a very good primary stability. We check the implant position. We remove the abutment. Finally, the implant position is checked with a probe. We rinse the surgery side and place the healing abutment. Check it by hand, and the control X-ray shows the correct implant position and a nice internal sinus lift. Let me leave the digital world for a few moments and let's talk about our temporary crowns. For single implants, mainly in the aesthetic zone, we want to achieve an optimal shaping of the gingiva by immediate provisional restorations. For this, we often use the abutment that comes with the implant. We form the elastic pro-temp crown from 3M aspe to the gap and polymerize with ultraviolet light. Thereby, the abutment is fixed in the provisional crown and can simply be shaped with acryl outside of the mouth to a high-quality temporary crown, as you can see on the right side. What did we achieve? We obtain a screwed temporary restoration without using any resin or cement in our surgery site. For me, this is the best solution to shape the gingiva in the healing period. Our temporaries are taken out of occlusion. Of course, you can also use a temporary abutment from the legacy system as shown here. On the right side, you can see that we get a screwable, high-quality temporary crown. I want to show you some more clinical images. On the left side, the interactive implant, and on the right side, the temporary abutment. To the left side, the finished provisional crown, and on the right side, the temporary crown immediately attached. After the healing period, we have a very beautiful emergence profile. Furthermore, on the right side, you can see the definitive ceramic crown. Now that we have been dealing with single crowns, we come to a different treatment concept of our practice. The immediate fixation of provisional denture with the GPS anchor. Let us watch a film. First, we insert the surgical template. Then the punch of the gingiva, again taking off the template and removing the punch. A reinsertion and fixing the template on the jaw with the anchor pins. Drilling through the cortical bone with the initial drill, reducing the sleeve diameter, and gradual preparation of the implant cavity. Transferring the into-guide drill length to the original drill and final preparation. What is missing? The screwing of the legacy implants. Number 1, initially by machine. Then the last turns by hand. Always the same procedure, identical until our last implant, number 4. We remove the surgical template. We extract the teeth. And remove the abutments. We check the implant position again with a probe. And connect a GPS anchor. Finally, we check it with the torque spanner. We start with the prosthetic work steps and fix the female elements on the GPS abutments. Polymerize them into the prepared interim denture. Thus, the patient leaves our clinic with a stable, fixed, temporary denture. Already, after 4 weeks, you see a well-healing gingiva. After the healing, we provide the patient with a metal-reinforced palatal-free implant denture, either on GPS or on bar attachments. Again, a similar case in the lower jaw. Immediate fixation of GPS attachments. You see the small wounds of the anchor pins. On the right image, the polymerized GPS attachments in the prosthesis. But again, the opinion of the patient has changed in the healing period. Suddenly, it should be a fixed bridge. Of course, we make everything possible. Thus, we decided to provide the patient with a shortened bridge, removable by screwing connection. On the left side, you see the CAD/CAM milled bridge framework, and on the right side, the ceramic finished bridge. On the left side, the clinical situation with 4 legacy implants, and on the right side, the fixed abutments. We glued them intraoral into the framework to guarantee a passive fit. On the left side, you can see the finished bridge and on the right side, the incorporated restoration. A further treatment concept of our practice is the restoration with the bar joint denture. In this case, we have placed 4 legacy implants with a surgical template. During the healing period of 5 months, the patient was able to carry his existing telescope prosthesis. We have prepared the definitive prosthetic restoration for the day of extractions. On the right image, you can see the bar attachments connected to the implants. Here you see the dental technology in detail. The bar attachments on the right side, the bar joint denture. We extracted the incisors and we were able to incorporate immediately the definitive restoration. Indeed, we provided the patient with a stable, definitive prosthesis without temporary dentures. Now we come to the edentulous patient. From the total denture to a fixed bridge over a provisional immediate restoration. Let us read again in the guidelines of our German Professional Society for Dentistry. There we can read for implant restorations in the edentulous maxilla. Especially in the edentulous maxilla, a detailed planning is essential. In the interest of backward planning, initially the prosthetic planning has to take place. For the implementation of these guidelines, we use the method named the radiographic guide. On the left picture you can see the duplicated full denture, marked with pink gutta percha. We need these markers to get radiopaque points in the CBCT because we don't have the teeth for the superimposing. On the right side, you see the gutta percha markers in the CBCTs, illustrated in pink. The patient CBCT with the radiographic guide and the CBCT of the full denture alone. These 2 scans are automatically superimposed by the program. That is the principle of the radiographic guide. How this works we can see in a short video clip. We see the full denture scan. Using the gutta percha markers, this X-ray is superimposed on the patient's CBCT, so that we can carry out the implant planning. In the left maxillary sinus, you can see the planned internal sinus elevation. Recognize the tooth-determined implant positions with 8 implants. The sleeves to attach the template on the jaw, you can see the colored drill sleeves and the anchor pins. Once again, the complete planning result. After planning, we can carry out the treatment of the patient and show you the clinical procedure. First, you see the surgical template with colored drill sleeves. The prepared temporary shell VitaCut Temp manufactured with the milling machine Arctica of KaVo. Let's start again with the gingiva punch. Take the surgical template off again, overwork the punch so that the gingiva can be removed. Thereafter we fix the surgical template on the jaw with the anchor pins, showing us a very accessible surgery site. With the initial drill, the cortical bone is pierced, and we begin with the gradual preparation. First, the smaller drill with a diameter of 2 mm, using 3 mm drill, then increasing to the final size. The final shape of the bone cavity is carried out with the original instrument. Initially, we use the surgical unit to install the ankylous implant. Then we switch to manual screwing. If it is too tight, you have to rotate one turn back and then forward again to the end position. Also, a bone condensation can be carried out with the osteotome through the sleeves. Important in the flapless procedure is always the check of the bone cavity with a probe. We show you once again an internal sinus elevation through the surgical template and the insertion of the collected bone chips. Finally, the mounting of the last implant and we can remove the surgical template. The overall result and the control of the stability with period test before starting the prosthetic steps. We fix the temporary abutments, correct them, and cement the temporaries after relining. The final restoration was carried out with CAD/CAM manufactured metal framework, cemented on titanium abutments, a ceramic finished bridge, and finally the control with a panoramic image. I hope I showed you an overview of our various treatment concepts that we use in our dental practice since the implementation of digital planning with a huge success. Let me close by saying digitally we come closest to nature. Thank you very much for your attention.